Newer therapies for the treatment of rheumatoid arthritis, so they'll have relevance to other diseases as well. And for that, we're very pleased to have Dr. Roy Fleischmann who's going to take us through this. Roy?
Thank you, Artie. So I want to put in a plug for Peter's talk. So Peter is the other person who was there building the ark with Noah with me. And Peter is, I'm sure, is going to have a very interesting perspective of what we've achieved and what we have yet to achieve. So I'm really looking forward to that talk. This is Rheumatology Year in Review, Rheumatoid Arthritis Newer Therapies. Are there any people associated with the pharmaceutical companies in the audience? No. Oh, there are some. So let me tell you right off the top, it's got to be published. It's got to be presented at ACR EULAR. It can't be a press release. It can't be a top-line result, and that's what I'm going to present. So if you have data that you know is coming, which I actually may know about, right? I'm not going to talk about it unless it's published. So I just want to start off that way. Okay. So I'm going to talk about tocilizumab. And tocilizumab is a very interesting drug, and there's been a lot of discussion. And there's been discussion about dose tapering, dose stopping of drugs. What do you do when a patient really does well? But tocilizumab actually asks a different question. And it brings up a different question, and that is, we know it works as a monotherapy. And the question is the monotherapy as efficacious as tocilizumab combined with methotrexate? Or you can reverse it and say, is the monotherapy, maybe it's not quite as efficacious, but has it compared to other drugs. But what do you do with a patient who won't take or cannot take methotrexate? Where does monotherapy stand? And I know that every time I go to an ad board, I'm always shown the same slide, which I think somebody made up and just dispersed to everybody, that 30% of patients worldwide on a biologic are not on methotrexate. And that concerns me because clearly with the TNF antagonist, every TNF antagonist, every study that's been done has shown the combination with methotrexate is clearly superior to a monotherapy TNF. And I think the same data has been shown with rituximab, but those were really small studies. I think it was shown. With ABBA, I haven't really seen a study, but my feeling is that maybe it is, but I don't know. But TOSI is different. And TOFA, which some people think is an oral IL-6, it really isn't. It's a very different mechanism of action, also raises that question. So this is an important question. I will say that the 30% of patients who are not on methotrexate and they're doing well, I haven't seen any data about how well they're doing. So are these patients who start off with a DOS of 7 and they're on a monotherapy TNF and they're at 5? They're doing better, but they're still really, really active? I've never seen that data, and that's data that would be interesting. So that's background for this, because this is important. So there were several studies that were presented over this year which try to address this question. And this was, Gerd Burmester presented the function study, and it was a very interesting study. It was tocilizumab plus methotrexate versus tocilizumab versus methotrexate in early RA. So you got to remember this is early RA. And what they did was they took a lot of patients who were methotrexate naive. They had to have less than 10 years of disease. They had to have a DAS28 ESR greater than 3.2, so that defines moderate disease activity. And they had to have an increased ESR or CRP, but they also had to have a positive rheumatoid factor anti-CCP erosions. So this is not a population in which I would have any doubt that these patients all had rheumatoid arthritis. And the primary endpoint was at week 24, and it was a strange endpoint to me. It was a DAS28 remission rather than other. Maybe not inappropriate, but not a usual endpoint. And the secondary was a change in sharp score, modified sharp score, and the HAC. And this was, I think, primarily an ex-US study. So the mean methotrexate dose was low, it was 15 milligrams a week. So you can see here that what they had, whoops. Where's the, this is one with the pointer. So So they had a placebo group, but the placebo group, of course, isn't placebo, it's methotrexate. And then they had tocilizumab 8 milligrams plus methotrexate, which is the standard worldwide, except in the small country called the US, where you have to start off with 4 milligrams. And then they had the monotherapy, which is 8. And then they had the approved dose in the US, approved starting dose of 4 plus methotrexate. And there are many people who think that the 4 is not quite as efficacious as the 8. So they actually looked at a number of things. And this is what they found. So this is a DOS-28 remission. And the drug worked well. If you take a look at the green is Toci 8 plus methotrexate. And they had 45% of patients achieving a DOS remission by month 6. And the second group was Toci 8 mono. And the third was Toci 4. And one would take a look just numerically and would say that 8 plus methotrexate works best. 8 mono doesn't work quite as well, right? But it works. And it actually works better than 4 and 8. If I knew that there was power to actually show a difference between the groups, that's what you would say. I don't think it was. But that's what it looks like. And take a look at week 52, it's the same. Toci 8 is better than Toci 4. Toci 8 plus methotrexate is better than Toci alone. Well, that's my interpretation. And the DOS remission in placebo looks pretty accurate to me. And radiographic progression, very little radiographic progression methotrexate. Why is that? Why isn't it 10 units? Because its early RA started with methotrexate. Methotrexate is a drug that works and does inhibit or slow radiographic progression. And Toci, either mono or in combo, but certainly the 8, seems to do a little bit better. So these are statistically significantly different and probably over the long term clinically important. And then they looked at Boolean remission. And you looked at Boolean remission, you got a little different result. And that was the 8 plus the methotrexate statistically was, and the 4 plus methotrexate was statistically better than mono and both better than methotrexate. And that's at week 24, which is the primary week 52, you're getting survivors. And it shows the same thing. I don't know if these numbers are that much different, but what it does suggest, again, is the combination with what I think is actually the appropriate dose of Toci seems to work better than mono, but mono does work. And these are the ACR 20 responses. They're really pretty close. And then there's another study. It's called Surprise. And this is out of Japan. It was Professor Takeuchi was the first author. And this is an add-on or switch. So it's open label, not the same as function, much less patients. And they had to have a DOS-28 moderate disease activity. Early RA in Japan is less than 10 years. Methotrexate greater than 6 milligrams, because that was their usual starting dose up until about 2 years ago, the maximum dose up until about 2 years ago. And the primary endpoint was the same, DOS ESR remission at week 24 in the per protocol set, and that's important. So those are the patients who actually took the drug, came in for every visit, and you're really watching them. And it was a non-inferiority analysis. And this is methotrexate plus Toci versus methotrexate going to Toci. And if you take a look, it failed, which meant that the anon was superior to the mono. Right? It failed. Now, I'm not going to get into differences in superiority trials and non-inferiority trials, but it's the difference between the two that you pre-select that can make a big difference. The point I want to make here is that when you look at secondary endpoints, look at the ACR 20 responses, ACR EULAR remission, they were the same. So maybe it's the endpoint. The endpoint can tell you, pick the endpoint, I'll give you the results you want. So different endpoints will give different results. So this is the ACT-RA 2-year outcomes. What I want to say about the first two studies is I think it's important. I think the tocilizumab plus methotrexate is the appropriate combination. I think that 8 is better than 4. If I can get to 8, I would, and that's what I would use. In a patient who cannot take methotrexate, won't take methotrexate, what am I going to do? I really don't want to put them on a TNF. I don't know about ABA. I don't know about Rituxan. but I do know that patients will respond to TOSI. So TOSI becomes a first choice. And indeed, in the new EULAR guidelines, that's exactly what's stated. The TOSI is the first choice in a patient who can't or won't take methotrexate. So this is the ACT-RA 2 years outcome. ACT-RA was a very complicated study, and I'm not going to go through it. I thought the first 6 months were really interesting. The second 6 months, I didn't know how to interpret the data. The second year, I certainly didn't know how to interpret the data. But what was important is this, and we're talking about discontinuation. What they did was they allowed a lot of medication changes in the second 6 months of the second year, and so it's very confounding, but they stopped tocilizumab if the patients were in a DOS remission for 24 weeks. If the patient was in DOS remission, they stopped the tocilizumab. And what they found was 50% of patients were able to stop because 50% were able to reach a DOS remission. And what happened was by 90 days, 50% of those flared, and 86% by the end of 1 year. This would tell me that if I'm treating with tocilizumab and the patient really has a good response, you got to have a really good reason for me to stop the tocilizumab. A really good reason. Not, I don't want to take medication. Not, it's too expensive. Because it seems that it works and you need the drug to continue to work. And my suspicion is that that's true of most medications long term. Okay, this is Samacta. This is tocilizumab IV versus sub-Q in DMARD IRs. And this is a study that showed that there was no difference between using tocilizumab IV or sub-Q. It was a 24-week double-blind with a 72-week open-label study. And it was TOSI 8 IV Q4 weeks versus TOSI 162 every week. And the primary endpoint was non-inferiority, and it was found. So I have no difficulty in using sub-Q versus IV, and I've switched IV to sub-Q, started sub-Q. The drug works. And this is Bravacta, Masashi. These were extension studies. So Samacta, we talked about. Bravacta was using 162 every 2 weeks. It was in Japan versus tocilizumab IV. And Masashi was a 2-year open-label data of 162 every 2 weeks, also in Japan. So all these studies were positive, and the drug has been approved as sub-Q, and the FDA recommended dose of Actemra is 162 every other week for patients who less weigh than 100 kilograms, and for patients who weigh more than 100 kilograms or don't have a sufficient response to every other week, then you can use 162 every week. And data would support that. I thought this was interesting. This is post-marketing in Japan. And what this study showed was it's an open-label study, and it's a safety study. And they take a look at the SAEs and SIEs, and we all know that they occur, and who cares? Well, we do care, actually. But if you take a look at the SIEs, they were associated with patients who are greater than age 65. We discussed yesterday that age 65 is actually teenage. RA greater than 10 years, respiratory disease, or prednisone greater than 5 milligrams a day. And that's what's associated with SIE. And patients were more likely to do well and not obtain an SIE, serious infections, if they had short disease duration, milder RA, fewer comorbidities, less concomitant steroid use, and less previous biologic. But what I want you to focus in on is this. This is the risk of SIE with a number of baseline features. If you don't have that, you're 55 years old, you have RA for 5 years, no respiratory disease, and no prednisone, your risk of an SIE is relatively low. Give a little prednisone, it triples. Make that patient 66, it goes up 3 times. And if you use 3 of those, it goes up. So it's very important to really assess the patient in terms of what you're doing, in terms of the drugs and comorbidities and how you're going to use them. And I think that this open label, post-marketing look really makes the point. And this is something else that was presented at ACR, and I show this really because I thought it was a very unique way of showing side effects. So we know you do a long-term open-label extension, you get side effects, you get LFT elevation, and I never know, is it once, is it persistent, is it high? What happens to it? Does it go away by itself? Do you have to treat it? And this analysis, which was, so Mike Weinblatt, it was a poster at ACR, I would take a real close look at it because it actually gives me a lot of data about what to do, in this case, with tocilizumab. So you know that 84% of patients never had an ALT, whoops, sorry about that, an ALT greater than 84%, 16% did. Half of them, it resolved doing nothing. Half of them, something was done. So it's a very interesting way of looking at it. So Artie asked me to say, okay, what's my experience? So there's no question it's effective. I don't think that there were unusual AEs. Why are they not unusual? Because it's been very clear through the development program, there are elevated lipids, there's neutropenia, it's what we expect. They're well documented. And I do follow the lipids. And if the lipids go up, I treat it, but I should do that with all my patients. I do check the white blood count. I don't do it the day after they get the IV or the sub-Q. I do it right before they get the next dose, because that's really when you want to look at it. And we do have some abdominal complaints, but I haven't seen a perf. I do think the patients do better with methotrexate, but I do have a few who won't or can't. And I've had limited experience with the sub-Q, but results that are similar to the IV, so that mimics the trials. All right, rituximab. So these were two studies that was shown at ACR. So this is a meta-analysis comparing low dose, 2 times 500, and the high dose. And it shows that they're the same in groups of patients. And it's something that a lot of people think about. Should I be using 500 milligrams of rituximab versus 1,000 times 2? At our table at TREG at ACR, we had someone from the UK who said this was incredibly important because they were under a lot of economic pressure. And the 500 is of benefit. And there was a second study, which was how fast do you have to infuse, because you're going to temperature for 5 hours. There was a second study that showed, no, you could actually do it at 2 hours. It was safe, as safe as the standard longer. And long-term safety, I'm not going to show this long, because it's 10 years, nothing's changed. All the concerns we had about rituximab in the beginning have not yet really been manifest. Nothing's changed, even knocking out the B cells. ABBA, we have the 2-year results of the AMPLE trial. So the AMPLE trial was patients with methotrexate, incomplete responder, and they were treated with either ABBA or adalimumab. So this is the appropriate use of ABBA, adalimumab with methotrexate in patients with moderate disease activity. And surprisingly, what it shows, surprisingly to most people, show the kinetics of response of ABBA was identical to adalimumab. The depth of response was identical. It's not slower, it's not weaker, it's identical. It's maintained for 2 years. The radiographic progression was identical as well. And safety, it's a small group. There's not a lot you can say, but there were some more SIEs in the adalimumab group compared to ABBA. And some more SIEs. It does fulfill the thought that many rheumatologists have that ABBA is a little bit safer. And maybe it is, maybe not, but this is a small study. This is a poster that I presented, and it was relationship remission, low disease activity and functional radiographic outcomes. And it's very complicated, but basically what it shows is, I could pull any part of this, whether you do a DAS28 remission, and this is the DAS28 CRP, something I wasn't happy with, RAPID-3, CDI, SDI, or Boolean, no matter which one you used, if the patient got to remission, you had inhibition of radiographic progression. Same thing with improvement in the HAC. This is looking at, I can't read it, achieving DAS28 CRP. That was low disease activity or remission. These are between the two groups was the same. Reduction in fatigue was also the same. So if you achieve good level of disease control, patients do well, radiographically, physical function, fatigue. So what's my experience with ABBA? I think it works as well as any other biologic. It has a similar kinetics of response. I'm really not sure that it's safe for my patient population. I don't really have the data. I have people on AB who've gotten sick. So I think that whether 2 people out of 100 get sick or 3 or 4 people out of 100 get sick, I have to worry about patients can get sick. I am using more sub-Q now. It does seem to work as well as IV. Tofacitinib. So I presented the 2-year oral START study, radiographic clinical functional comparison of monotherapy versus methotrexate, and these are methotrexate-naive studies of patients. So this was 5 milligrams or 10 milligrams BID, monotherapy, or methotrexate escalated to 20 milligrams a week with a mean dose of methotrexate of about 19 milligrams, different from function. And what this showed was ACR 20, monotherapy 5 and 10, better than methotrexate. Methotrexate was pretty good, right? It was, 42%. But both doses of tofa were better, and they were the same. ACR 50, better and the same. ACR 70, better and the same. Patients with no progression in X-ray, statistically better, and probably the same. This has been used to take to the FDA to get radiographic slowing or inhibition into the label, and I think that that's coming up for a decision pretty quickly. So what this shows is that tofa 5 and 10, clinically functioning radiographically superior to methotrexate over 2 years. And I can tell you that my take on this data is I'm not sure that 10 is better than 5. I'm not sure. Everybody talks about it, but I'm not sure. And I'm not sure that you need methotrexate with tofa, because these results are as good as combination. The studies haven't been done. They haven't done a study where they've looked at 5 and 10, where they really can see whether one is better than the other, and they haven't done the study of mono versus combination. Malignancies, that was a big concern when tofa was approved. Are they increasing over time? They're not. Big deal was made about tofa having a half-life of hours, and therefore it's really safe. Well, it takes 2 weeks to get the CRP back to normal. It takes 2 weeks to get the NK cells back to normal. 4 weeks for the neutrophils to get back to normal. A week for the DAS-ESR, and 2 weeks for the HAC. So although it has a short half-life, its PD can last several weeks. I'd also like to point out this, and this is the DAS-ESR. So everybody says, well, you're going to use this twice a day, patients aren't going to take it, you're not going to get the effect, they're all going to become crippled. And I asked the patients very directly, are you taking the tofa? And those of you who know me know that I really do ask it directly, right? And the answer is, yes, I do. And why do you take it that way? Because if I don't, I can tell. Because that's actually the quickest change. So my experience with tofa, I think it works as well as biologics. I do like to use as monotherapy for the for the same reason I would want to use toci as monotherapy. I'm not convinced the methotrexate adds efficacy, and it's not unusual AEs. It's follow the same AE pattern as they do with tocilizumab. These are molecules in development. You can see that some of them died. That's DC, right? Fasti already killed, right? Alexion, not Alexion, Olocazimia, the UCB IL-6 has been put into retirement. IL-6 inhibitors don't really work in RA, but one company thinks that it may. The anti-BAF, anti-BLIS of Lilly has been put to rest. But there are new drugs. There are dual targets here, which are interesting getting into development, and other mechanisms. So there was a report of Vertex's 509. It's an oral JAK3 inhibitor. It's thought to be more specific than tofa. This is plus methotrexate incomplete responders. You can see the study. It's a tofa result. different doses, good response, ACR 50, ACR 20, 50, 70, decrease in DOS-CRP, decrease in the HAC. And you take a look at the AE profile, it's a TOFA result. Now, they think it's a more specific JAK3 and maybe it should be safer. They're going to go into phase 3, or they are in phase 3, and we'll see. But it clearly works. And there's baricitinib, which is a JAK1/2 inhibitor. Previously, I presented data on the phase 2 in the US. This is 2B in Japan. Same results. And these are ACR 20, 50, ACR 20, 50, DOS remission, SDI remission, normal function HAC, looking at different doses. The doses that are going forward are 4 milligrams and looking at 2 milligrams if the patient can't tolerate 4. But it does work. And it's safe even though it's a JAK1/2, not a JAK3. It looks like a JAK3. And this is INC. It's a selective JAK1 inhibitor. This is a huge study of less than 50 patients with a lot of groups, right? 10, 12 people in a group. And it's phase 2. Patients that have active RA. Some had TNF failures. Oral. Primary endpoint was at day 84. No severe AEs. So some ALT increase. No dose. And dose-related increase in LDL. And when this was presented, we said, well, this is a pure JAK1. Artie, you're smarter than me. Can you have a pure JAK1? Can you have a JAK1? What? Oh, there are no JAK1 homodimers. So it's a JAK1. You can't have a JAK1. So this is going to be a JAK1 something else. I actually asked the question, so is a JAK1 what? I said it's a JAK1. I said it doesn't exist. It's JAK1 what? Right? But the results, they look great for the 600 milligram dose in 11 patients. ACR 20 of 91%, ACR 50 of 64%, ACR 70, 55. I want to see this repeated in phase 3 in a real population. But it probably works, and it probably works like TOFA. And this is clazakizumab, and this is really interesting. So this is an IL-6 inhibitor. It's used with or without methotrexate. This is a drug from BMS. And you can see they had all these different doses. And these are ACR 20 responses and 50 and 70. It's very confusing because they have all these different doses. And what did you see? And what you saw was that any dose of methotrexate, clazakizumab, 200 of methotrexate, 25, 100, 100. I'm doing the wrong place. 25, 100, 200, 100. With methotrexate, all those did slightly better. Now, the monotherapy didn't do terribly, but it seems like with tocilizumab, same thing. You do better with methotrexate. And the other thing you see in this dose-ranging study, which is what this is, that dose is this, 25. They didn't have a dose response. They probably have to go back and redo the study using the 25 milligram as the highest dose, because to get FDA approval, you need to show the highest effective dose. You go higher, there's no more effect. 25 seems to be that, but you also have to show the least effective dose. And they didn't show it. Not in the study. But it seems to work. And then there are a number of other drugs that you have listed in the slides. These are drugs that are they're not ready for prime time. They're out there somewhere. And these are the drugs that are past prime time, all right? So we're not going to hear about the IL-6 from Mark Genovese anymore from Lilly. It's been put to rest. This is secukinumab. You'll hear about it in psoriasis, psoriatic arthritis, but not in RA. Didn't seem to work. And Fasti. So Fasti was a very interesting drug. Sick, right? When this program started, the expert panel was different from the TOFA panel. Everybody was friends, but we talked about which one's really going to work. Well, they'll probably both work. But Fasti didn't, and there are signs and indications that they didn't look at in phase 2. So in phase 2, there were 2 studies, methotrexate and complete responders, where it seemed to work, but they identified the safety signals of hypertension and diarrhea. Now, Mark Weinblatt presented it, and when I said, patients don't really like diarrhea, he said, it's not really diarrhea, it's just frequent loose stools. And I said, well, patients don't like frequent loose stools either. And he said, well, but you have to understand these patients were from Mexico. And I said to him, but Mike, I thought it was the gringos going to Mexico that get the diarrhea, not the Mexicans. And his response was, next question. Well, that actually, so it was the diarrhea, the hypertension that was really a problem. Safety was not in its favor. And there was a phase 2 efficacy study, which I think is very important, Oren. And Oren, is Oren here? Okay, Oren. This is directed right there. Phase 2 study in methotrexate failures where the drug failed. It failed. But the explanation of this was that, well, there was a site that didn't do this right. If we only looked at CRP, but the MRI showed that it worked. So let's go by that MRI. So they do this big phase 3 program, including X-ray, and you know what happened? It failed because the MRI was too sensitive, not validated. But it's okay. Anything else? Nope, that's where I wanted to go. All right, so with that, I'm ready for questions.
All right. Well, thank you, Roy. Let's turn it over for questions and discussions. If you do, please, if you do come up to the microphone and introduce yourself. There's a race on the left-hand aisle here. Let's start out with Dr. Trump. Arn, front left.
Roy, that was a very nice presentation and overview. Just one, Roy.
I'm hiding from the dart.
Just one point of clarification. The MRI has been validated for using in the use of rheumatoid arthritis in randomized trials. I agree with you, though. I wouldn't base my opinion on an MRI, and it's just an adjunctive way to assess patients with RA.
We'll discuss later.
Roy, great job as usual. One point I would like to see get your comment on.
If we had done ultrasounds, it would have been very effective.
That's my point I was going to make. You needed a highly sensitive ultrasound. No, Roy, for the first time, it looks like we're getting close to the holy grail. I mean, we're getting ACR 20 responses that are approaching 100%. I mean, do you think that this is the future of looking at these targets? I mean, getting these ACR 20 responses of 80, 90%? I mean, that's really amazing when you look at our oral small molecule.
Artie asked me not to be my usual self, all right, and make fun.
But that didn't work.
It didn't work, but it's not going to work now. So, Alvin, you have to really take a look at the data and how the data is done. So that was a phase 2B study, or phase 2A study. It was a very small study. It was really a phase 1. And it's very few patients. And I forget where it was done, right? But I wasn't impressed by where it was done. And phase 1 studies, generally, what I see is ACR 20s of 70, 80, 90%. And you get into phase 2, all of a sudden it drops to 70 and 65. And you get into phase 3, it drops into 55 and 60, right? So I don't know that you're talking about the Insight, JAK1, which did that, but I've shown you that before with other compounds as they go down. TOFA, when TOFA did the original phase 2A, it was ACR 20, 50, 70, like 80, 70, 60. And now we talk about 60, 40, 20. So you got to look at the trial. If we did have ACR 20s of 90, that'd be okay. And we'd like to know what the ACR 100s are. Jack?
Good morning. That was a good presentation and a good overview. You know, it seems like in your review of this, there's a lot of action still in the small molecule development area. But you didn't recover very much what seems to be a lot of action in the IL-6 development area. Where do you think that's going? I mean, again, we have one on the market, and it seems to have some impact, and it's slowly growing, but there's a lot of new other IL-6 competitors coming out. Is there going to be room for them? Are we not using enough of that particular therapy? What do you think?
I think we have to bring Jack to Maui, have him live there, right? Great ideas, great questions, much better than in Dallas, right? But those are really key questions. So I started out by saying I'm only going to present data that was presented at ACR EULAR. So I didn't present, I really didn't present the newest data with the Sanofi IL-6. I didn't present any data with Janssen's IL-6. It wasn't presented, right? But I really have the same question as you do. So these IL-6s may have a different mechanism of action, maybe a monoclonal antibody against the receptor, or it may be against the IL-6 itself. I haven't seen any difference in efficacy or in safety between them. I really haven't. So, you know, there are, what was Vivica talking about, 12, 13 drugs out there now? And you have 4 or 5 IL-6s and a bunch. We'll have 30 drugs. But I'm not sure there's going to be a difference in the IL-6s. And I think the key for the companies that are developing them is, you know, what's their niche? And I don't know. It's a great question.
Yeah. All right, back right microphone.
Okay, I have a question about the tocilizumab monotherapy. How does that compare with the adalimumab or etanercept data?
So Artie could answer this question better than I can, but I'm not going to let him. So he did the study, which was ADACTA, which used tocilizumab monotherapy versus adalimumab monotherapy. So the problem with ADACTA was that that's not the correct way to use adalimumab. You want to use it with methotrexate. But you have to understand that what they did was they took, and correct me if I'm wrong, they took patients who are intolerant or would not take methotrexate, which is about 30% of the population.
They had been exposed and stopped for reasons either at the physician or patient discretion.
And they had stopped it. They weren't going to take it, right? And that is 30% of the population. So it's a real population, and tocilizumab kicked the butt of adalimumab. The first way they did it was you do a CRP response or DAS, or what was the first one?
Well, it was a DAS, but then it was known as a CDI.
No, then you did the CDI. Yeah. You showed the CDI. Because once you show the DAS, the IL-6s are really good in reducing CRP. And then Artie, in his own little way, said, oh, but let me show you the CDI. There's no CRP in it. And the response was exactly the same. And I think that's the reason why when EULAR came up with its newest recommendations, it's very clear that the first biologic of the patient is not taking methotrexate should be tocilizumab. I think that that's correct.
She also asked about etanercept. Do you want to talk about
etanercept? Etanercept monotherapy, I think, is very much like adalimumab monotherapy.
Tempo?
What?
Tempo?
In tempo. Well, no, also there was a study that, the Moreland study that we did from the phase 2 study. Etanercept works better with methotrexate. It's very clear. And without methotrexate, if you do a monotherapy, it's the same as methotrexate. You know, I don't think that, if I'm going to use a monotherapy, I'm going to use tocilizumab or tofa. Those are the two that I would use.
All right, Jack, quick question.
Yeah, quick one. And practical, a lot of people haven't maybe used as much TOFA as you have, and you talked about maybe you don't need methotrexate, but I think people are faced with the issue of going from someone on methotrexate and they're going to switch to TOFA. Maybe they're dropping a biologic in the way. Do they continue methotrexate? What's the evidence that they should drop it or continue it?
Yeah, Jack is probably the highest prescriber in the U.S., actually, I want you to know, which is true. But the issue is, I'm going to throw it back to you. What I do is if a patient comes in and they're on methotrexate, they've had an incomplete response, I'll add. And if they get a really good response, I'll begin getting rid of the methotrexate. If they begin flaring, they go back on methotrexate. I have had a few patients, as you know, because we've discussed, where I've started TOFA as the first drug, monotherapy, for very specific reasons. You know, a young female tells me getting married and she's going to want to get pregnant in a year. And if I start on methotrexate, I know it's going to take 6 months for it to work, and I have to stop at 3 months before she gets pregnant. With TOFA, it's going to work a little bit quicker, and I could probably stop it a month before. If someone wants to get pregnant at a later time period,
You could wash it out.
I can wash them out faster, right? Jack is bringing up another point. There is a TNF that I could use, which is Cimzia, right? But it's a monotherapy.
right, one more quick comment, Peter?
Very, very interesting presentation, Roy, as always. But what I'd like to know is your personal thoughts on the thinking that you go through when you pick one of these agents. Because more and more, except for Artie's trial where, adalimumab without methotrexate didn't look as good as tofa. But as these drugs are compared, the few comparisons that we have, as you showed one today, they look the same. And if you compare the data from different trials, they all look the same. In fact, you could actually have a generic response slide and just put in the drug, and it would be okay. So the question is, in the situation where you have a bunch of drugs, and please don't talk about the insurance issues, just where you have a bunch of drugs and you have a patient sitting there, what kind of mental algorithm do you go through in order to identify the drug you think would be most appropriate for that particular purpose?
Yes, I agree. So the issue is I never think about insurance, and your points are all well taken, and it's exactly what I think. I can't really tell a difference between one and the other in all reality. I think I can handle the side effect profile of all of them. And I do give patients all of the options. And it takes time, as Marty will tell you. But I can go through it pretty quickly, and I start out by saying we have these drugs. In groups of patients, I can't tell the difference. Their safety is relatively the same. Some of them are oral, some of them are IV, some of them sub-Q. Any idea? Any choice? And they may give me the choice. Or they may say, doctor, I want another one that's the longest one out there. Or they may say, I saw Phil Mickelson, what about that drug? I like that drug. So I really don't have a favorite. It's whatever will work in a patient. And I'm going to change if they don't respond. For all the reasons you pointed. Thank you.
All right. Thank you, Roy.